To our webinar on pediatric diabetes update. As you can see, we have a few people who have already signed in, and we're waiting for more of our viewers to come online. Feel free to have your lunch. I mean, this is, after all, diabetes. I'm not going to be counting carbs with you, and I can't see you, so go ahead and enjoy as I chat through this. Just let me tell you a couple things about who I am and what I do. I'm the Director of Diabetes Services at Children's National. I'm presently also co-chief of our division, and we take care of about 1,800 patients in the Virginia, Maryland, and D.C. area, as well as some patients from Pennsylvania and West Virginia. So we have a lot of patients. We take care of type 1, type 2, and all the different kinds of diabetes that are unusual, including neonatal diabetes, cystic fibrosis-related diabetes, and diabetes secondary to medication. And what my plan today is to try to update you on what we're doing and how we're managing children. I will start this off with a case and then work our way through this. So if my children's people want me to continue, let me know and we can move forward. So I actually have no financial incentives at this time. I do have some volunteer positions. I chair the examination committee for the National Certification Board for Diabetes Educators. This is the group that actually certifies diabetes educators. So if you've seen the CDE designation, that's what that is. We have an exam for all the people from the various disciplines to become certified diabetes educators. So it's not just physicians, it could be any kind of healthcare personnel. I'm also on the Safe at Schools Committee for the ADA, in which we work for advocacy for our children at schools. And I'm a referee for the Science and Technology section for the ADA annual meeting. I also serve on the Diabetes Clinical Advisory Committee in Washington, D.C. Okay, let's do the next slide. So my hope is after we have this discussion, and I'm hopeful to have, could you go back, please? I'm hopeful at the end of this discussion that we can have these main objectives realized. I'm hoping for time at the end for people to ask questions. It is important that I take into consideration that you'll be seeing patients in your office, and that I'd like you to be able to understand what we, when we send you letters, what they mean. So firstly, I'm going to ensure that everybody can identify signs and symptoms of diabetes in your office. I'm going to discuss the latest basal and bolus insulins and how we apply them to construct insulin regimens. And then I'm going to discuss and classify the different kinds of diabetes. As everyone knows, it's not just type 1 or type 2. Next slide, please. So this is a typical presentation that I'm going to walk through with everybody. I have found that people become more engaged when they actually have a patient to discuss and how we might manage them. So this is a 4-year-old that presents to your office with a history of wetting the bed with increasing frequency over the past several weeks. The history of the present illness is significant in that the child's been drinking more, but it's summertime, so mom was not all that concerned. He goes to the bathroom on his own and has been at day camp, so she really is unsure how much he's urinating during the day. He does, however, interrupt play to run into the bathroom. He does have a good appetite, no fever. He had a URI several weeks prior to the visit, but otherwise well. Past medical history, frequent episodes of otitis as an infant, but no other major illnesses. He did have varicella 6 months ago, and he apparently broke through the Varivax. Otherwise going well and physically active, currently on no medication. Next slide. His immunizations are up to date, no allergies. Family history is very significant. His father had type 1 diabetes diagnosed at age 21, and his paternal aunt and uncle died from complications of type 1 diabetes in their early 20s. The aunt had what we call now diabulimia, which is essentially an eating disorder, whereby she omitted her insulin and ended up in DKA and died from cerebral edema. And the uncle had a car accident in which he was killed due to severe hypoglycemia at which time at the accident he was unresponsive. There's no history of type 2 diabetes. There is a history of low thyroid, no history of celiac disease or juvenile rheumatoid arthritis. Social history, the child lives with his parents and 7-year-old sibling. He is, as we mentioned, currently attending summer camp. That's not a diabetes camp, obviously. Physical exam is notable for a blood pressure of 100/72, pulse 90, respiratory rate 28, temp 98.7, weight 18 kilos, height 105 centimeters. Next slide, please. The physical exam was notable for no rashes, no acanthosis nigricans, HENT was negative. He did have a palpable thyroid, clear lungs, cardiac normal, abdomen was borderline tender, question rebound, no liver or spleen that was increased. The rest of the exam was absolutely normal, normal mental status, etc. Next slide. Next slide. So you're in your office, and of course for me everything is diabetes, but in the general pediatric setting you have many, many ideas to run through your mind, and I think it's important to run through differential diagnostic considerations. And general pediatricians routinely do this, and I just wanted to say what goes through my mind that you should pretty much rule out before you start thinking of diabetes. Of course, you're going to check out nocturnal A lot of families, as you know, would come in thinking this is a UTI, but you know as well as I that 4-year-old males with UTIs would be very rare. If this was a neonate male, then you might be worried about some sort of congenital birth defect with posterior urethral valve and reflux, but again, this is a 4-year-old boy. If it were a 4-year-old girl, it might be more reasonable to rule out a UTI, but as you'll see in a few minutes, you'll be able to take care of this in your office. Another very important consideration, which we teach the med students and residents, are psychosocial issues. Is there a new sibling? Is there divorce? Has the family relocated? Death in the family? Is there any abuse that you can ascertain? Any one of the top 10 stressors can cause changes in any kind of behavior in these children. And of course, the mother has already ruled out drinking too much before bedtime by limiting the amount of fluids the kids are drinking. And you've already in your office have ruled out a neuropathic bladder. You should have known this from previous exams, such as a spinal cord abnormality or an abdominal mass. And then we would rule out nuanced diabetes insipidus, and then, of course, the big one we're talking about here is ruling out diabetes. Next slide, please. So you're in your office. You all have the ability to look at a urine. So you do. In your urine, you see 4+ glucose, moderate ketones, trace protein, negative nitrate, negative leukocyte esterase. You have a negative micro, and you have a high specific gravity of 1030. And in many practices, I am aware that you might have a glucometer. And of course, the problem with that is, of course, you have to have OSHA come and make sure you keep regulations up. But assuming you do have a glucometer, and in this practice they did, and they did a finger stick glucose, and it was 300. So already you're very concerned about the possibility of diabetes. And so you go through these differential diagnostic considerations in your office based on these lab work. So one of the things you immediately see is hyperglycemia with ketosis, and the first thing that should pop up in your mind is to rule out probable type 1 diabetes mellitus based on the BMI of this kid with normal height and weight. You've ruled out a urinary tract infection because you have negative nitrate, negative leukocyte esterase, and negative micros. You do have a strong family history there with the father having type 1 diabetes. You should know that there's a probably much more possibility of type 1 diabetes in a child if their father does have diabetes. I believe a 6% increase. Not particularly the same for moms. There's also a history of thyroid disease, and this child does have a palpable thyroid. You've ascertained that there's no evidence of new stresses in the family. He has a normal neurologic exam, and there's no evidence of GI. Next slide, please. So your leading diagnosis based on presentation, physical exam, and if you recall, there was no evidence of acanthosis nigricans, which is significant for insulin resistance, more leading toward type 1. You also have a positive and strong family history of autoimmune disease, type 1 and thyroid disease. And so in your office, your most likely diagnosis is new onset diabetes, mostly type 1. So I'm hopeful that you've called our either pediatric endocrinology team or the emergency room and sent this child for further evaluation. In this case, the family did, and the following are the laboratory tests. The random blood sugar was 375. Once again, the urine ketones were moderate. Sodium was 132, not surprising in view of the high blood sugar. Chloride 3, BUN was 18, moderately elevated, creatinine 0.9. pH was 7.3, bicarb 15, and the hemoglobin A1C was 11%. So what we can tell here is that the child is probably borderline acidotic. A definition of DKA would be a pH less than 7.3 and less than a bicarb less than 15, so he's not in DKA. The hemoglobin A1C clearly indicates that he has very, very high blood sugars. Basically, his blood sugars are clearly over 250. So we know that this kid clearly has diabetes. Next slide, please. So in summary, the signs and symptoms of diabetes in association with a random blood sugar over 200 gives us our diagnosis as one of the diagnostic criteria. This is the typical presentation for type 1 diabetes, but I want to make clear that you cannot base this diagnosis on the finger stick that you got in your office. You do need to get a venipuncture blood sugar, and in this case, they did. There are really 3 other ways to diagnose diabetes, and often you see those in more slow presentations, and particularly with type 2 diabetes. So the way to do that would be to get a fasting blood sugar on 2 separate occasions over 126 milligrams per deciliter, or do an oral glucose tolerance test, and the results would be over 200 after 2 hours postprandial consumption of 75 grams of carbohydrate. Another way that is often done now is obtaining a hemoglobin A1C that would be greater than or equal to 6.5%, which would be a 3-month blood sugar average of about 140 milligrams per deciliter. Those are the 4 diagnostic criteria, and to reiterate, this child met diagnostic criteria number 1, number 2, and number 4. Now, one of the things that happens typically when we're on service and we get calls from the ER, we get cases that might be mistaken for new onset type 1. And the way they may present would be similar to the way this 4-year-old presents, and additional history would note that these children may be ill, they may have bronchiolitis, they may be on, they've received a hit of dexamethasone in your office, or they could be on acne medicine that might cause hyperglycemia, or if they're on other medication that can cause hyperglycemia, you could get presentations that look like this. So what we do in the emergency room, in order to rule out any of these cases that might look like type 1, we would get a rapid result for a hemoglobin A1C. And hopefully, if they're less than 6, then we can rule out, we could say that this might be stress-induced hyperglycemia, et cetera. So keep in mind that not every presentation with hyperglycemia in the emergency room is necessarily type 1 diabetes, and an A1C would be very useful to rule that out. So in summary, we have new onset diabetes, most likely type 1, based on criteria numbers 1 and 4. Next slide, please. So the way I teach my students and everyone else is to think like a pancreas. How would a pancreas work to manage hyperglycemia? So what I'm going to do now is I want you to think logically and to understand what insulins we do use, so that when you see one of your patients in your office with diabetes, you know when you go through their medications how they're using and what they're doing. So, for example, in order to treat patients, we need a background insulin, which is a basal insulin, to cover blood sugars when they're not eating or sleeping. And we need a bolus insulin to cover their blood sugars when they are eating or when their blood sugars become very high. So the basal insulins currently in use, and you'll see them all the time when you see your patients, is glargine. Glargine actually is a relatively new player in the basal insulin category. It was developed in 2001, and basically it's given in a profile where it's flat, which is great, and I'll show you that picture in a minute, and it lasts 24 hours. There are three versions of glargine. One is Lantus, which was made by Sanofi-Aventis, and then Basaglar is relatively new on the market, made by Lilly, and they're both basically the same medication. They're glargine, and with a 24-hour flat profile. Toujeo is a type of insulin that is glargine, but 3 times more concentrated. So you have to be very careful that if you're ordering glargine, you make sure you know which kind you're using, because if they use different pens, which they should not be, you might give 3 times the amount you want. So, for example, if you wanted 30 units of either Lantus, Basaglar, or Toujeo, you would get the same amount, but the volume of Toujeo would be 1/3. And this is really helpful in patients that require large amounts of glargine. So we don't have to give a huge volume. You might want to consider Toujeo. And these are in patients generally that are often exhibit insulin resistance, such as type 2 patients. Another basal or background insulin is Detamir, otherwise known as Levemir. The profile for this is 12 to 16 hours. It's flat. It was originally marketed to be a once-a-day insulin. However, in our type 1 patients, we find that we actually have to use it twice a day to get 24-hour coverage. The newest kid on the block is Degludec, otherwise known as Tresiba. This is an insulin from Novo Nordisk, and it has a 48 to 72-hour life, flat profile. It basically could be used once every 3 days, but we don't recommend that because it has a steady state profile pharmacokinetically describing it. So we have to be careful with this because we really can't adjust it but for every 72 hours. I tend to be cautious when using this in children because especially with newly diagnosed patients, we're constantly making adjustments. And then the last insulin, which has been around for a very, very long time, is NPH, otherwise known as neutral protamine Agadorn insulin. And this lasts 8 to 10 hours and has a peaky profile. And I'll show you a cartoon of that in a minute. Now, what about the bolus insulin? So we have to take a basal or long-acting insulin and match it up with the bolus or rapid-acting insulin in order to cover carbs and lower blood sugar. So when kids are eating or have high blood sugars, we use generally one of the rapid-acting insulin. Lispro is one brand from Lilly, otherwise known as Humalog, and it starts working right away. The profile is such that it lasts about 1.5 to 3 hours. It's usually over by 3 hours, peaking around 1.5. Same thing with Aspart, which is Novolog, and that peaks in about the 1.5 hours, gone in 3 to 4 hours. And then one that you may be less familiar with is Glulisine or Apidra, peaking in 1.5 hours and lasts about 3. Unfortunately, we really don't have much choice in using one of these insulins because insurance companies are dictating which of the kind of basal or bolus insulins we need to use. Unless I can find a reason that I'm not happy with any of the basal or bolus insulins, I am required to use what the insurance companies dictate. If I don't want to use it, I have to do probably like you do, a prior authorization. Now, there's also regular insulin, which we call fast-acting, and that starts working in about 30 minutes and lasts 2 to 4 hours. This is the kind of insulin that Banting and Best discovered in dogs, and this is human insulin now. We do use regular insulin only in insulin drips, and on occasional times I might use it as a bolus insulin if I need to. The other thing I want you to be aware of are pre-mixed insulins. We tend to use these pre-mixed insulins in patients that are not adherent and parents that are unable to understand how to mix insulins or use basal or bolus insulin. So you might see Novolog mix, which is 70-30, 70% long-acting insulin, 30% short-acting insulin, and we call that attenuated. And then there's Humalog mix, 75% long-acting, 25% short-acting. And then there's Humulin, which is 70% NPH and actually 30% regular. Next slide, please. So I am including this just for your reference. Whenever my students see this, you can hear a huge groan because they look at this in the small print. But I did this to give to you basically a total chart of all the insulins that we use with their onset, peak, duration, and other important factors, what they look like, et cetera. So I would just say keep this for your reference, and that's what I ask my students and residents to do. If you have any questions on how they work, there it is. Next slide, please. So this is actually the ideal way our pancreas works, and indeed, if you look at this, you could see how we might do this. Now, Randy, if you go to the next slide, I'm wondering if I can show how it works. Go to the next slide, please. Yes. So as you can see, the purple line indicates basal insulin. That could be given at either bedtime or in the morning. Basically, it needs to be 24 hours apart, and that would be something like glargine or Dedimer. And then, as I said, it's given once a day. Dedimer I would do twice a day at breakfast and perhaps bedtime. Next slide, please. Brandy, next slide. So what you can see is now I've shown that we add a bolus insulin, as you can see at breakfast, which then works very quickly to cover all of the carbs and to lower blood sugar. Next slide, Brandy. Same thing at lunch. Next slide. And dinner. If someone decides to have a snack, say between lunch and dinner, we would ask them to give a bolus using Novolog, Apidra, or Humalog to cover the carbohydrates and lower their blood sugars between meals. We also recommend not doing extra corrections or lowering blood sugars more than every 3 hours because that places the patient at risk for hypoglycemia. Next slide. So that's called prandial insulin, which is the same as bolus. Next slide. Okay. What I did not include, because it's very rarely used with the NPH and regular, and I don't think you're going to be seeing that very much, so I figured I would just show you basically what's called basal bolus insulin therapy, which is what the previous slide did. And this would be a typical, let's say your patient now is going to be admitted to my service, and this is the way I would start insulin. And I'm doing this because for all I know that you may be someday practicing and there may not be a diabetologist or a pediatric endocrinologist where you are, and I kind of thought this would be helpful to you to see about how I would start a first insulin dose. So a typical starting dose would be between 0.6 and 1 unit per kilo per day. And this is in a child not in DKA. If a child is in DKA, or diabetic ketoacidosis, I already know that they're somewhat insulin resistant because of all that glucose toxicity. And in them, I would use 1 unit per kilo per day. So I start them out in a regimen that's called modified basal bolus, and I'll show you what classic is in a bit. So I'll start out by using a basal insulin such as Lantus, Levemir, or Basaglar, and do 40 to 50% of the total daily dose. And then the bolus insulin, which would be Humalog, Novolog, or Apidra, I would do 50 to 60% of the daily dose. So for this 4-year-old who's 18 kilos, I picked 0.85 units per kilo because he does have some ketones, and I get about 15.3 units. If I take 40% of that total daily dose, I get 6 units required for basal insulin, and that can be given in the morning or at bedtime. And then the remainder, to cover his meals, I get 9 units, and I just divide them by 3, breakfast, lunch, and dinner, and give 3 units breakfast, lunch, and dinner. So the starting dose before this kid goes home would be glargine, 6 units of glargine at bedtime. and then Humalog, Novolog, or Apidra 3 units before each meal. So then we said this is a great start, but what do you do to fix higher blood sugars initially before moving to more intensive insulin therapy, which I'm going to discuss in a few minutes? We add what is called a sliding scale until the family returns to our class to learn about using ratios and correction factors. Next slide, Brandy. So here's how you would do initial sliding scale. What we would do is say, where do you want this kid to be? Where is an ideal blood sugar for this kid? And that really is based on age. In a school-age child, I would probably say anywhere over 4, I would use a target of 150. And that's because I don't want them to go low. In an adult, I'd say, gosh, I would be at 100 or 120. In a toddler, say a 2-year-old, I'd want to be a little higher at 180 because, again, we're always worried about hypoglycemia. So the first thing we do is calculate initial sliding scales. So after we get the target, we say, what is the correction factor? In other words, how much insulin do I have to give to lower this kid's blood sugar? And some brilliant endocrinologist named Bruce Bode, about 10 or 15 years ago, figured out a way to do a mathematical calculation. What the constant is 1800, and we divide the total daily dose of that into it, and we get what's called the correction factor. So that means the amount, 1 unit of insulin will lower the blood sugar, which if you realize is based on this child's unique total daily dose. So we go 1800 divided by 15, which we determined at our last slide, and that equals 120. So what does that really mean? It means that if we give this kid 1 unit of insulin, that will lower the blood sugar by 120 milligrams per deciliter based on his insulin requirement. Now, what we have to do is calculate a sliding scale in the hospital, because if I did that formula in the hospital, they wouldn't let me write that in Cerner, okay? So what we do is a sliding scale. I'm going to show you the next slide. Next slide, Brandy. We say in our Cerner orders, we make a sliding scale for a target blood sugar of 150. So we say, for this kid, when he eats, if his blood sugar is less than 150, give 3 units of insulin, because that's what we figured out before. But if his blood sugar is between 150 and 210, we would give 3.5 units of rapid-acting insulin, because, if we recall, 1 unit will lower the blood sugar 120. Therefore, a half a unit will lower the blood sugar 60 points. So then we do for every 60 points, and you'll notice I'm using half units. We do have half-unit syringes, and you draw it up or use a pen, and I develop what is called a sliding scale. This is a real sliding scale, not made up, and it's, remember, based on this child's total daily insulin dose. And I went up to 390 here. I could keep going up to 500. Of course, I hate seeing 500, but this is what we could do. Now, what do we do once the kid gets out of the hospital? Much quicker and much easier. We do the following algorithm. We take whatever that kid's blood sugar is. We subtract the target, and we picked 150 for this kid. And then we divide by that correction factor I calculated for you in the previous slide, which was 120. This time we have to use the 1 unit lower than 120. And we then come up with the amount of extra insulin to lower the blood sugar added to that base of 3 units. So if we do the calculation, 350 minus the target of 150 divided by 120 equals 1.66 units of correction insulin. Now, I would not necessarily do the 1.66. I'd probably round it up or down, and I would do 3 units for the food plus 1.5 or 2 units rounded and give 4.5 to 5 units. Little kids, I'd probably do 4.5. So that would be the amount of insulin you'd need to give that kid at a meal based on 3 units for the food plus lowering the blood sugar from 350 to 150. So then what we do next, we follow the blood sugars for several weeks, and then we send them to a class to learn how to do much more intensive insulin therapy, where they can apply what's called an insulin to carbohydrate ratio and correction factor. Randy, next slide. Okay, and I'm going to get into that later, okay? basically, I think what you need to know is that the insulin to carb ratio is also another algorithm, and based on that, we can determine if we give a ratio, say 1 to 8, 1 unit per 10 grams, 1 unit per 8 grams, and that, in addition to the correction bolus, determines how much insulin we give. And that's a whole day class that we do. So I wanted to now talk about what kinds of diabetes that we have and how to differentiate. The key to remember is that not all type 1 or type 2 diabetes is those two types. You now have so many kinds that we need to learn how to differentiate between them two. So I wanted to go over the differences between major kinds and what we actually see in the office. Type 1, pretty much everyone knows, rapid onset, polyuria and polydipsia, weight loss, and there's generally an autoimmune etiology as origin. And that you see in the chromosome 6 or HLA region. And people inherit either low risk, moderate, or high risk. And in children and families that have diabetes, it's high risk alleles. We obtain GAD65 antibodies, and they're positive. These kids also have a risk for DKA, thin phenotypes, and they're all treated with insulin. Now, not everyone is GAD positive, but if you finally obtain many, many types of pancreatic antibodies, you often find that there is a positivity for one. Now, type 2, as you know, is a gradual onset. They're often obese phenotype with an evidence of insulin resistance. And you can see acanthosis nigricans on the neck and the interdigital areas. There is a possible weight loss. They truly may present with ketones. And indeed, they can present with DKA. And that's often a sign of confusion because people used to think that only DKA occurred with kids with type 1. Actually, that's not true. They can present with, type 2 patients present with DKA, and when they do, they're very, very sick because, as you know, it takes a long time for them to lose the ability to produce insulin. And these kids can have high morbidities and make us very, very uncomfortable. We treat these kids with metformin, which is the only FDA-approved oral drug for our type 2s, and often insulin if necessary. Indeed, if their A1Cs are higher than 9 or 10, they definitely go on insulin. Then we are often seeing more and more patients with a combination of type 1 and type 2. These are the kids with a phenotype of type 2, meaning obese, presence of acanthosis nigricans, but when we do lab work and look at autoimmunity, they often have positive GAD65 antibodies. And what we do with these is treat them as though they were type 1 unless they start producing endogenous insulin on their own. The other type of diabetes we're seeing, which is very, very interesting because it has been only diagnosed around, I would say, for the last 10 years, that would be monogenic diabetes, including neonatal diabetes. We've all known MODY, or mature onset diabetes of youth, has been around for a long time, and that's a genetic form of diabetes. But diabetes presenting in neonates was basically unheard of, and everyone thought that was type 1. And actually, in patients that present at birth to 12 months, most of these kinds of diabetes have to do with genetic defects in insulin receptors. In these patients, once we get the genes for that, we can often start them on high-dose oral sulfonylureas and get them off insulin and treat them like type 2s, but with lots and lots of sulfonylurea, much more than we would do in adults. Brandy, next slide, please. And then the other kind is medication-induced diabetes. And you see this actually in your own office, kids that are on steroids for asthma or other autoimmune diseases, et cetera, as well as children who are receiving chemotherapy for neoplasia or other diseases, arthritis, can develop steroid or medication-induced diabetes, which require insulin therapy. This is one of our toughest types of patients to take care of because they usually have an underlying disease which requires a lot of care. And those patients that are on the bone marrow service or on our oncology service are asked to do chemotherapy, and then when they develop hyperglycemia, my team has to come and tell them that they need insulin. And it's the amount of stress induced is enormous, and patients often are not particularly adherent. The other form of diabetes, which is becoming more prominent, is cystic fibrosis-related diabetes. That's called CFRD. And this is related to the destruction of both exocrine and endocrine parts of the pancreas. So, of course, the exocrine function is for digestion, and the endocrine function is for the beta cell. We treat these as we treat type 1s with insulin. Again, this is a very tough group to take care of because the good news is that they're living long enough to develop CFRD. But then we're asking them, in addition to their regime of pulmonary toilet, we're asking them to take insulin. And these kids also, we don't worry about how many carbohydrates they're eating because the dietitians and pulmonologists want them to eat a lot of carbs to maintain their weight. So we're often struggling to get the right amount of insulin to keep their blood sugars stable and prevent them from getting hyperglycemia, which only adds to more pulmonary problems because the bacteria in the pulmonary tree love sugar. So these kids come in with pulmonary exacerbations, and then what we do is try to get the blood sugars under control using both basal and bolus insulin. And then lastly, diabetes secondary to pancreatectomy for often hyperinsulinemia, and then when they take out a large part of the pancreas, they lose beta cells, so we have to treat them with insulin. Next slide, please. So what about technology in diabetes? As you are seeing probably in your office, you're seeing more and more technology. This is really, in my years of experience, which has been about 30 years taking care of kids with diabetes, we've watched technology become an incredible large part of our visits in terms of what people are using to monitor blood sugar and deliver insulin. So the biggest thing that we are looking at now is insulin pump therapy and continuous glucose monitors. The basic types of pumps that you might see in your office are the three that I'm listing here. One is the Medtronic Mini-Med pancreas. The newest version on the block is called the hybrid pancreas, which does sort of come in the middle between an artificial pancreas, which is a marriage between the pump and a sensor, and helps lower blood sugars by talking to each other. This is just starting, and it's complicated. It's recommended for patients over 17. The regular Medtronic Mini-Med, basically you program insulin to carbohydrate ratios, which determines the amount of insulin you need for food, and you program in the correction factor, as I just taught you. And then you program in basically the amount of insulin you wish to be delivered every minute, called basal insulin, which is essentially Lantus, but delivered very slowly over 24 hours. And you program that into the computer on the pump. You use tubing and a catheter to put it under the skin. This is not a surgical procedure, and it flows. And the pumps that are generally in use are the Medtronic Mini-Med, the Tandem T-Slim, which has a cool touch screen like an iPhone. And then the Omnipod, you may have seen, looks like a little mouse that's on your body that's tubeless. Basically, you use a PDA to program it from afar. Now, the bionic pancreas, which is developed by Ed Damiano in Boston, uses two types of hormones, insulin and glucagon, in tandem. And the way that works is taking the pumps, any one of these eventually, and putting in glucagon, which is the hormone that actually raises blood sugar. And then the hope is that you can use the two of them to talk to each other by using them to do feedback on each other. Now, I put them under bionic pancreas for all of them because I think that's what's going to happen. The model that Ed Damiano used is none of those. But I'm going to say that it's very possible we can use any one of those three once Ed figures out how to marry the insulin pump to the continuous glucose sensor. Now, we do have sensors out in use presently. One is called the Dexcom. And what's wonderful about this is you put a sensor on the body that can stay on you for 7 to 10 days, and it measures tissue juice glucose. And it which I'll show you in a minute, looking at blood sugars minute by minute. You can also set alarms, so if you go low overnight, it alarms so they know what to do. And the problem with this, though, is that the alarms can sometimes be a problem. You know, you're in the middle of a classroom and you keep getting alarms. So the kids often shut it off, and then that's the end of that, because that's supposed to help you determine what to do for treatment if you're low. The newest kit on the block is the Freestyle Libre. This is just approved by the FDA. The difference with this is that you have a sensor on it which requires no calibration, which means you don't even have to do finger sticks, and you take a meter and wand it over the sensor, which gives you a blood sugar. The downside is that there are no alarms, so parents are very nervous with that one. The other thing is the FDA just approved the use of these CGMs without checking blood sugars. And many of us are very anxious about it, because if you're not using the continuous glucose monitors effectively, you can have they may be not matching each other, and then you do not effectively treat a high or a low. So as you could probably figure out, adherence is a huge problem with this. And our goal is to be able to get people to choose what they want to do, and we don't force people to use technology. But if technology is used effectively, it could really do a better job in managing diabetes. Randy, could you go to the next slide, please? So this is what I wanted to show you what this looks like. What you could see is on the left, the pump, and the using Bluetooth, where you can, I'm sorry, I shouldn't say pump, sorry about that. You could see that this is the sensor there, and it's through an iPhone. If you use the receiver or even an iWatch, you can get the information from your sensor to your phone or the receiver, and the iWatches are really cool because the kids look at the iWatch, uh-oh, I'm high. And the other thing that's really amazing is parents can follow the blood sugars from a distance. And so they're watching their kids' blood sugars, and schools have gotten calls out, Johnny's blood sugar is 20, you better go do something. Of course, that could also be intrusive. My teenagers hate this because it seems like their parents are watching over all their blood sugars. So, you know, you have to do a balance between that. So this is really cool technology through the iCloud. Next slide, please. So this is another way to look at a different sensor. Here's, you can see the